Okay, here we go. Mark, set, go. Maybe. Okay. All right. Okay, we got a big lecture. I've got lots of slides on here. So I'm not going to be going over every single slide I have on here in detail, but I mainly put them on there as a study tool for y'all. Okay. Anyways, so pregnancy problems. We're going to start with gestational diabetes, which is diabetes because of the pregnancy. It's not diabetes. The woman's diabetic and now she's pregnant, so now she has gestational diabetes. This is a diabetes that develops because of her pregnancy. And then usually in the first part of the pregnancy, she doesn't have any issues. It's the second half of pregnancy that we do see her issues with blood sugar problems. And it is an insulin resistance problem. It's not an insulin, yes.
So I had a question. There was a question on the quiz.
Mm-hmm.
It was talking about a woman who was pregnant and had a risk of diabetes or something like that.
Mm-hmm.
And one of the answers was to start A1C and serum testing at 24 weeks.
Mm-hmm.
And then the other one was something about type 2 diabetes. And it said the answer was type 2 diabetes.
So if she on that A1C, if she scores at a certain level on that A1C, then she's diagnosed with overt diabetes, not gestational. Is that what the?
So the thing, I chose the one about the A1C and the serum because in the book it said something about doing those testings starting in the 20-something weeks, and I didn't pick diabetes.
No, but it's her first visit, and then so it says you should do it as soon as possible.
But it's not diabetes type 2.
It's relating to the risk. It says she's at high risk for gestational diabetes, and it says in the book that if you're at high risk for gestational diabetes, they need to start testing immediately.
Instead of waiting for the standard.
Yeah.
We'll look at that at the end of class. Okay. All right. So here are your high risk factors for developing gestational diabetes. Okay. So during pregnancy, they want an even tighter control of your blood sugars because uncontrolled blood sugars can really adversely affect the baby to the point of severe developmental problems, severe malformations and things like that. But anyways, so these are our fasting is less than 95 before meals is less than 100, and 2 hours after meals is less than 120. So they do a lot of 2-hour postprandial after meal type blood sugars on pregnant women. Okay, so it's not always the typical before meals testing blood sugars. Okay, and because she is pregnant and has diabetes, it makes her diabetes more uncontrollable, and so she has, with her pregnancy, she has these increased risk factors. And here are your baby risk factors. So congenital anomalies are a huge thing with brittle diabetics, or people who are uncontrolled diabetics and then they get pregnant. Their babies can have severe congenital anomalies that probably will be incompatible with life. So we really like to see these people pre-pregnancy to get them under control. Okay. All right, so when we have women that are high risk for overt diabetes, we want to start their screening as soon as possible in their pregnancy. And then so when we do the A1C or fasting blood sugars, If there's any that are greater than, if their A1C is greater than 6.5, or fasting blood sugar greater than 126, then they just get diagnosed with overt diabetes. So this is the person that has never been diagnosed with diabetes, gets pregnant, comes into the clinic, she's high risk, and so you start the screening as soon as you get her, pretty much, depending on when she shows up. And then if any of these values, if she exceeds any of these values, she's diagnosed with overt diabetes, not gestational diabetes. Okay. So typically, we don't start screening for gestational diabetes until about 24 to 28 weeks. And there's two schools of thought on screening. It just depends on which your physician uses. If he uses the Diabetic Association screening protocol, which is the 75-gram 2-hour glucose testing, we do 1 hour and a 2-hour blood glucose level, and if they exceed any of these values, then they're diagnosed with gestational diabetes. Okay. The other screening protocol is ACOG, American College of Obstetrics and Gynecologists. They do a 50-gram 1-hour screening. You can. This woman can do this one at any time, so she doesn't need to be fasting. And then if she is above those parameters, right here, if she's greater than 130 or 140, then she will do yet another 3-hour 100-gram glucose screening. So that's ACOG's requirements. So, or that's their recommendations, ACOG's recommendations. So it just depends on what your physician uses. Yep.
I'm still hung up on this overt diabetes. So if it's before 24 weeks and there's a high, so your mom has a high risk, she has all those risk factors, it's before 24 to 28 weeks, they do that screening immediately, and then if she's in those parameters,
If she's above those parameters,
then she's going to have overt diabetes.
then she's just going to be diagnosed with diabetes.
And so overt diabetes is just diabetes.
Mm-hmm.
It would kind of be the same as if you came in.
And she wasn't
DM.
pregnant, and she came in,
Okay.
and someone, yeah.
Okay, so it's a, all right, got it
Okay.
now.
Caitlin.
Can gestational, like, it usually goes away with pregnancy, right?
Mm-hmm.
Does it ever continue?
So she's at high risk for developing overt diabetes later in life, at a higher risk. And she's also at a higher risk for having gestational diabetes within pregnancy. So usually postpartum, it just kind of goes back to normal like all of a sudden. But we do watch them up to 6 weeks to make sure that their blood sugars are stabilizing back to pre-pregnant, non-gestational diabetic levels. All right, so usually with gestational diabetes, it can be diet controlled. However, they may need to have insulin, and then depending on if they have the intermediate or regular or combination, they usually get referred to a diabetic specialist to have their insulins regulated. So we don't usually use orals. We usually just go with the insulins. Okay. A typical protocol is a 4-dose regimen where they take their regular before each meal and then their NPH at bedtime. We usually don't use, like I said, oral agents with these women. However, they are trying to decide whether or not glyburide or metformin might be options.
Question. Is regular insulin cross the placenta, or is it just rapidly absorbed?
Right.
And does it have to do with it being injected subcutaneously, or just the nature of the drug?
I think it's more so the nature of the drug, because it does get in mom's system. So the oral glycemics, they do, hypoglycemics, they do cross the placenta and then cause more issues with baby,
Okay.
as opposed to the insulins, which don't. So postpartum, they usually decrease. So postpartum, they can take oral glycemics unless they're breastfeeding. And then we keep assessing them up to 6 weeks to make sure their blood levels, or blood glucose levels, return to normal. Okay. Any questions about diabetes, gestational diabetes? We will now start talking about anemia. There's several problems with anemia, or several different kinds of anemia. It is the most common complication in pregnancy, inadequate iron intake, which is why we do have these gals take prenatal vitamins and even additional iron supplements, okay? Depending on if they do have, if they have an anemia, a diagnosed anemia, they'll probably be on also additional supplements, iron supplements. If they don't have a problem with anemia, they'll probably just be on prenatal vitamins, okay? So these are the problems that mom can have. You can understand this. If you have anemia, you're going to be easily tired and all those kind of things. So these are pretty standard here. Baby, so it can cause problems with baby. So if we don't got, mom's not got good oxygenation, good blood flow, a good amount of red blood cells, then we're not going to have good exchanges through the placenta. Okay, so these are what your baby's going to look at. These are what your baby's going to face. Now, you guys know about sickle cell anemia. Have you covered that?
Mm-hmm. Sort of.
So sickle cell anemia creates a problem for both mom and babe. They could go into mom could go into a sickle cell crisis. The pregnancy puts that much stress on her underlying condition. So these are high-risk pregnancies. Folic acid supplements for these gals, and then depending on if they have a sickle cell crisis, they may even need to be hospitalized and given transfusions. So the pregnancy, again, can aggravate a sickle cell crisis. And, you know, she could go into congestive heart failure or acute renal failure because of the stress that the pregnancy puts on her underlying condition. So here's our treatment if she is hospitalized. Now this is pretty standard for any patient, even if they're not pregnant. Okay, so I don't think this is anything new, except for now we're going to be monitoring her pregnancy throughout this crisis. So we have 2 patients instead of 1. And pretty much the same with any anemia. We're going to have a risk of preterm labor, intrauterine growth restriction, and low birth weight, just because we're not getting the good exchanges because we don't get good blood on mom's side. Okay.
Is there a difference between low birth weight and small for gestational age?
Yeah, so low birth weight pretty much means small for gestational age. You have that intrauterine growth restriction, which is a small underweight baby, but it's their growth pattern that presents the issue. So it's not that a baby is growing normally and just not growing enough weight for IUGR. But the low birth weight and small for gestational age, so they can be a low birth weight and be appropriate for gestational age. They're just
Okay.
low, okay? And then intrauterine growth restriction is kind of a different thing. So they've got some developmental problems with intrauterine growth restriction.
It's not just size.
It's not just size.
Got it.
And for intrauterine growth restriction, there's two different types, and depending on when the insult happened to the baby. So if it happened in the early part of pregnancy, their intrauterine growth restriction is what we call symmetrical, and you would think that would be a good thing, but that's not, because the insult came early when all the development was occurring, so they're having restrictions there. Whereas the asymmetrical growth restriction is baby did fine the first half of pregnancy, and somewhere in the second or even third trimester, that's when the insult happens. So everything has developed normally, but now the continued growth is restricted. So these are babies with really huge heads and really small bodies. Well, not really huge, but okay. So folic acid deficiency is a common problem. I think this is probably the most common problem. We give them additional supplements if they're diagnosed with folic acid deficiency. Okay. It's the second most common cause of anemia, but it's what I see the most. So you guys should remember it as the second most common. Anyways, here are our risks to mom. One of the big things about these all these anemias that we're going to go through is if she's anemic and then she has a delivery, she's not able to tolerate a huge blood loss. So an average blood loss for a vaginal birth is 500 cc's, and she could be at 300 cc's, and she could virtually be hemorrhaging for her own situation. Okay. So here is your way to beef up your folic acid is your diet. And then folic acid deficiency is linked to neurotube defects in our baby. Now, I've put these next few slides, two of them. These are those anemias in kind of a little chart. I don't know if this would be easier for you guys to study or the slides, so I just went ahead and put them in there for you. Any questions about anemia? Okay. I just put this picture up here. This is the typical appearance of a baby who's born with fetal alcohol syndrome. They have virtually no nose bone. Like, it just seems like it goes straight across their cheek, or they don't have a bone there. Okay. They have these funky folds in their eyes. Okay. Very small chin. They don't have this little ridge in here, and this real flat lip. Okay.
Is it a tall forehead too? Or is that?
I don't know so much if that's just a picture. I don't think tall forehead is a criteria for this one. All right, so these next few slides I've just put in here. They have the alcohol, the narcotics, the barbiturates, drugs that mom could be taking while pregnant. There's two of the slides. And it just breaks down kind of what baby's looking forward towards a mom who does drugs. So not only do we have a lot of intrauterine growth problems, like these kids come out, the cord's cut, they're no longer getting their drugs, and so babies go through severe withdrawal, and they have to be admitted to the NICU and put on medications, and they could be there for weeks and weeks. Okay, so I didn't put up any slides for the psyche of during pregnancy, so you guys can just look through that little section. We're going to move on to HIV. Okay. So I didn't put the slides up that says what HIV is. You guys can review that. I think everybody is quite aware today about HIV, but if you have any questions, be sure to let me know. But we want these gals on antiviral therapy when they're pregnant, okay? We want to do everything we can to keep the pregnancy happy or healthy and try to prevent transmission to baby in utero. HIV can be transferred during the pregnancy or through breast milk. So these women don't breastfeed after pregnancy or after they deliver. Okay, but the greatest risk to baby is at or around the time of birth. So these women are usually scheduled for a C-section before they go into labor.
I thought we learned somewhere that if you were taking drugs, you could breastfeed, and there was like a 0.1% chance.
So there's so when they do the testing, if the woman's been on antivirals and her if her levels are low, like below, I can't remember what it was, 1,000 or something like that, then she can be safe. But the general practice is if women aren't on antivirals or haven't had been taking it, then probably not breastfeeding. So that's just a determination of the pediatrician, and then they have to consult with the obstetrician and get mom tested and continue to test her throughout her breastfeeding. So the general rule is, though, no. Okay? All right. Okay, so when children are born, then they are also put on antivirals if they test positive, or if mom's not been on antivirals. So the recommendation is that if we don't get her on antivirals at 28 weeks or shortly thereafter, then we're going to automatically dose baby. Okay. Yep.
Are the cures in kids surrounding this? Do you know anything more about that? Are they still,
I don't know the statistics, but
Are they still-
it's pretty good if mom's been on antivirals and we get baby on antivirals right after delivery. I don't know what the statistics are, but I think they're pretty good.
Have they followed anybody
Huh?
much past those few years yet, or is that just pretty recent?
Don't know. Yeah, I haven't been following that research. All right, so if your patient has HIV, then she might have some other diseases that you'll need to test for. The big one being hepatitis B as well. I mean, hepatitis B isn't a sexually transmitted disease, but it's another disease that is common with the HIV infection. Here's your signs to watch with your mom. And if we do have a positive mom, we start doing fetal surveillance at about 28 to 32 weeks. We do the ultrasounds, the biophysical profiles, and we don't do any amniocentesis or chorionic villus sampling or anything where we could cause a cross-contamination. Okay? So they're scheduled for a C-section. Now, I think this is so if the results are less than this 1,000 copies and they've been on antivirals, then I think that's the the recommendation they use for breastfeeding.
And so they could have a vaginal birth also?
They could, yeah, they could, okay? But most of them are scheduled, most women are scheduled for a C-section. And it's her choice. Most women would rather go that route than risk a contamination. Okay. All right. Gestational problems. Now, we've covered abortion before. It's just in here as a reminder. It is the major cause of bleeding. And remember, abortion is any birth that occurs before 20 weeks gestation. Okay? Now, there's several different kinds of abortions. There's not just an abortion. You don't just have an abortion. You have a threatened one, you have an imminent one, you have a complete one, you have an incomplete one, you have a missed one. So a threatened abortion, they've called it a threatened abortion because this woman is bleeding, and we think she is going to abort unless we intervene. And sometimes we can intervene and stop this. Okay? But sometimes we can't. So she has bleeding, she has cramping, her cervix is dilating, so her abortion is imminent. Now, this doesn't mean that that night she's going to lose her pregnancy. It could take a day or two, okay? But it's important for us to know that when she does abort, whether she has lost all the products of the pregnancy. Because if she has not, and that's a complete abortion if she's lost all the products of pregnancy. But if she hasn't, an incomplete abortion will cause her to continue to bleed. All right? Now, the missed abortion is the baby has died, but she, yes.
If you detect what you think is an imminent abortion, do you admit the woman?
Well, it just depends on how much bleeding it is, and usually they send these people home. But if she's having lots of bleeding, having problems passing the products of pregnancy, then yeah, we'll keep her, because now we don't want an issue of continued bleeding where she's now hemorrhaging at home. Okay, so a lot of these gals do stay at home for this. Okay, so a missed abortion is one where the baby has died, but she has not aborted the fetus. And so these gals, they do need to be brought in, and basically they need to be induced. Unless they're, like 8 weeks or something like that, and they'll probably just do a D&C, but a lot of these women end up getting induced, going through labor, basically. Anyways, and it says if the fetus is retained beyond 6 weeks, like if you let that go to 6 weeks before you intervene, then you've missed the boat, or the doc has. Like, that's just cruel.
What is the DIC? What is disseminated?
Okay, disseminated intravascular coagulation. So this happens not just to pregnant women. It can be a complication of anybody who has a hemorrhage type issue. So if you're losing lots of blood, then your body is trying to produce blood to replace that. But it's trying to do it so fast to catch up with the hemorrhage that it ends up putting blood products out there, clotting factors out there in your system that are immature, okay? So you end up using up all your clotting factors, all the things that you're producing is immature, and then, so DIC is a syndrome where you're bleeding and clotting at the same time, okay? And it's really, really bad stuff. If someone goes into DIC, they're really circling the drain. Okay. All right. The recurrent or habitual pregnancy loss, that's just any abortions that occur 3 or more consecutive pregnancies. So this woman, she's doing everything she can to get pregnant. She loses it. She gets pregnant again. She loses it. She gets pregnant again, and she loses it. Those are recurrent or habitual pregnancy losses. And then a septic abortion is the products of the pregnancy become septic and the woman becomes septic, okay? She's had a back alley abortion and she becomes septic, so. Those are nasty. So here's a look at a threatened abortion. So the reason why they call this threatened and that we might be able to intervene here is the placenta has not broken away from the uterine wall, but she is bleeding. So if we can somehow get her to stop bleeding, bed rest, fluids, maybe we can keep this pregnancy going, okay? Now this one is your complete, imminent. So there's a little bit of placenta up here attached to the uterine wall, but the majority of the placenta has broken away, and she will lose this pregnancy. We cannot maintain this pregnancy with this much placenta, and it won't. It'll continue to dislodge. Okay. And so she's bleeding a lot with this one.
How much bleeding would cause concern?
Anything over 500 cc's is a basic rule of thumb for any pregnant person delivering.
Well, I mean, to think that you might have a threatened abortion versus just
An abruption or something like that.
Or, well, something that maybe wouldn't be concerned, like is spotting, or like, oh, we got to get to the doctor right away, or like...
Well, okay, so any type of bleeding that happens during pregnancy, especially the early parts of pregnancy, they do need to get to the doctor right away to make sure that that is not an abruption or an abortion of some sort. It could just be she has a low-lying placenta that is close enough to the cervix that blood is sloughing out, okay? Or it could be she has your cervix is very vascular. If you look at that thing too hard, it's going to ooze some blood. So, you know, it might have gotten a little traumatized during some activity and bleed, okay? So.
What about the people that have normal periods and are pregnant? Because you hear of that quite often.
Even having,
Mm-hmm.
well, so, you know, we have to make sure it's not placenta related, okay? And if it's not placenta related and they're bleeding and we can't find any, it's not the cervix, it's not the placenta, it's probably just uterus sloughing off in some area, it can't be around the placenta, okay? I mean, that's not terribly common, and there's nothing we can do to stop that bleeding. We just need to monitor it, and we need to monitor the pregnancy. Yeah.
Is this like an example of like a chorionic hemorrhage or something like that? That sound familiar to you?
Yeah, but this is not. So this is just an issue where the placenta is completely shearing from the uterine wall. If we have a situation where one of the amniotic membranes is having an issue, or we have some separation between the placenta and the, not necessarily the uterus, but the membranes, we will have a situation like that where the placenta is kind of like bleeding into the different layers, or between the two layers.
Can that be super dangerous for baby too?
Well, yeah, I mean, any blood loss on mom's side is going to cause a problem for baby. And if it's bleeding from baby and not from mom, of course that will be a blood loss for baby. All right, here's our, no,
Continue.
Incomplete.
no, I thought I had a slide of a complete, but I just have two. No, all right. Kind of have two, oh, I'm sorry, yeah, I got confused. So here was the one I just had, the imminent. So a complete one would be, I don't have a picture of a complete, but it would be, the whole placenta would be sheared from the uterus. and she would be bleeding and then lose the baby. So here's the incomplete one. So so she passes parts of the pregnancy, and in this case, she passed the baby part, the fetus part, and is retaining the placenta part. Okay. So, it can be kind of any combination where she passes the baby, she passes part of the placenta, or she passes the placenta and not the baby. So, so it's still a bleeding issue. All right. Any questions about abortions?
I have a question.
Yeah.
So with all of these, they can happen at any point of the pregnancy?
Well, for an abortion, it has to be
Before 20
over
weeks.
20 weeks. But
Okay.
yeah, I mean, they could be 19 weeks. All right, so other problems are ectopic pregnancies, gestational trophoblastic disease, placenta previas, or abruptions. So we'll just go over those real quick. Ectopic pregnancy is a pregnancy that is fertilized but does not travel out of the fallopian tubes. So the pregnancy implants into the fallopian tubes, or any place other than the uterus. Okay, and I mean most often it's in the fallopian tubes, but it can be anywhere in the abdominal cavity actually. Okay, and so these things are a big problem because this pregnancy does grow. Okay, and if it's in the fallopian tubes or somewhere it's not supposed to be, it's going to cause severe problems to those structures. And usually they're in the tubes ruptures, and she has bleeding, and it could be a really bad deal. So if you have a gal come in, she had a positive pregnancy test, and she's complaining of these symptoms, then you're going to be suspect for tubal pregnancy. Okay. Yep.
How do you differentiate ectopic pregnancy from other causes of pelvic pain or
So
abdominal pain,
right.
kidney problems?
Right. So you'll do here's those things. So you'll do these assessments. You'll do HCG measurements, and then the vaginal ultrasound is going to tell you.
You'll be able to see
Mhm.
like embryo or whatever in
Yep.
the fallopian tubes.
Mhm. Yep.
What is adnexal?
So that's over the ovary area.
Oh.
All right, so here's our treatments for ectopic pregnancies. Usually, so this drug is kind of not very effective, but anyways, because sometimes we don't catch these tubal pregnancies until they're a little more advanced. So this trophoblastic cell proliferation, so that's what's going to be developing the placenta and implanting into whatever site. So if we've already implanted and the trophoblastic cells are already grabbing on to whatever, this is not always so effective. So it's usually a surgical procedure where they go in and they try to, depending on how long this pregnancy has been growing in the tubes, they try to just cut that little area out, take that pregnancy out. Sometimes women lose their tube, okay, because it's done so much damage and they couldn't repair. And then always we're going to be giving RH immunoglobulin. So yes.
Can you still become pregnant with just one tube and one
Mhm.
functioning ovary?
Mm-hmm. So we give this to RH negative women because we don't know what the product of that pregnancy was, or what RH type that pregnancy was. Okay, so we go ahead and we treat mom for RH negative because she's RH negative. Okay, yeah.
Is it just as effective, like, if a mom with negative blood had a baby with negative, like, say it was an abortion,
Mm-hmm.
but you don't know, is it still just as effective whether or not the baby was positive or negative?
Right. So if you give it to Rh negative women, and you don't know what the fetus is, it's not a problem if that fetus ended up being Rh negative as well.
And it'll still protect her against the next one.
Well, yes, it will,
Okay.
okay? But she's still gonna be with the next one, she's still gonna end up being treated again, okay? All right, gestational trophoblastic disease. So what happens is this egg and sperm tried to fertilize, and what happened is those trophoblastic cells just ended up dominating, okay? And we'll see what that looks like. There's 3 different types you can see there. So what happens in this normal molar pregnancy or hydatiform mole pregnancy is so that egg that was supposed to fertilize and produce a fetus is now just these trophoblastic cells are just proliferating, and it just looks like a big blob of grapes. Blood-filled grapes, okay? And these things are what bleed, okay?
And they fill the uterus? Is that the uterus that we're looking at there?
Yeah. Let me go back. Oops. So anyways, for the hydatiform mole, or the molar pregnancy, there's 2 types. Of course, there's got to be 2 types of everything, or 4 types of everything. There's the complete or partial. So what happens with the complete is the egg is fertilized, but there's no genetic material in the egg. Okay? And then with the partial, we have a normal egg with normal genetic material, and then either 2 sperm fertilize that egg, which is not supposed to happen. And so now we have 2 sperm with a total of 46 chromosomes, fertilizing a normal egg with 23. So you have this, how many is that, 76? 69? Anyways, or you have 1 sperm that did not undergo that division from its parent cell to the 4 baby cells. So 1 sperm can have the 46 chromosome. Okay, do we get that? Okay, so the partial is we have a good egg, but we have 2 sperm getting that egg. So the 2 sperm having a total of 46 chromosomes, or we have 1 sperm that didn't do its meiotic division right, and it has 46 chromosomes. Okay?
Is it possible for the egg to have 46 ever? Or no?
Well, I don't think that they've ever documented that kind of deal. They've had, with the complete, it's like none.
So this would happen pretty early on in the pregnancy.
Mm-hmm. Yep. Okay, so the second type of gestational trophoblastic disease is the invasive mole. It's similar to the complete mole, but it has now implanted and invaded into the myometrium. Okay, and the choriocarcinoma is just a malignant form. So if a woman has a history of gestational trophoblastic disease, she has a really high risk of developing the choriocarcinoma in the future. Okay, and there's our picture. Here's our signs and symptoms. So we do have bleeding. We have an enlarging uterus. We may see those little clusters coming out instead of just bleeding. So blood loss, and then of course we have no heart tones.
I have a question.
Mhm.
So with this, they don't necessarily have like with a complete or incomplete. It still would give a positive pregnancy test.
Yeah.
Okay.
All right. So ultrasound is your diagnostic tool, and then to be 100% sure what you got going on, and then we need to do some sort of DNC to remove those products.
What is D and C?
Dilation and curettage.
Is it
Not to
dilating
be
the
confused with
cervix?
DIC.
Yeah, what's that?
Oh, I said not to be confused with DIC.
Right. For this, they really probably wouldn't need to do much dilation. They probably just suck it out. Okay.
What is curettage?
It's a little tool, actually, metal tool that has kind of like a, yeah, like a hoop type thing, and they scrape the uterus. So anyways, we do give these gals also the RH if they're RH negative mom. So we don't know what that product was, so we just treat her just in case. So the malignant form does develop, they are at higher risk for the malignant form, okay? So we will kind of follow this woman like once a year or every couple of years, just to make sure that she's not developing any type of carcinoma type deal.
Why is it a chest X-ray?
If it spreads. So we talked about the evacuation, hospitalization to do that. All right. Now we're going to go on to hyperemesis gravidarum. So this is hyperemesis is they're vomiting all the time. They can't stop. Now we know that morning sickness, women have vomiting a lot, okay? But this is beyond that. These people are going for days. They're not able to eat or drink every time they vomit, okay? So they can have severe hydration and electrolyte imbalances, hypovolemia, all those kind of things. They do need admitted to the hospital and monitored and put on IV replacement therapy. This is very severe. Look what we've got here. We've got starvation, muscle wasting, acidosis. This is hyperemesis gravidarum is not morning sickness. It's a severe condition of pregnancy. And some of these women are on TPN to get their nutrition. So this is the goals of our treatment: control vomiting, correct dehydration, restore electrolyte balance, and somehow get her some nutrition.
Do things like Reglan or Dancitron help with that?
So in an acute phase, there's a protocol that they use where they give IV fluid bags. Their maintenance IV bags have Phenergan in them. And then they give a piggyback of a napsine, like every 6 hours or something like that. They can give Reglan, but sometimes it's just so ineffective, even the IV fluids with the Phenergan in them. So, yes.
So is this something temporary, like early pregnancy?
Hopefully, but not always. Like, this can continue through pregnancy. We've had some women in this community actually who, there's a couple of them I know of that we've had pretty, on and off all throughout their pregnancy, all the way till term. These women had PICC lines placed, they had TPN on board, and they just managed their nausea and vomiting as well as they could at home. But some of these women haven't eaten hardly at all throughout the whole pregnancy. But hopefully after the first trimester, like, this does go away, but there's a few cases where it absolutely has not. All right, so here's some medications that we can be giving to these women to help with their nausea. And then, of course, they can be on TPN.
So these medications don't harm the baby then?
not as bad as mom
Not
dying.
eating. Okay. Yeah.
Yeah. Oops. Okay. So the fun stuff, hypertensive disorders in pregnancy. So there's 4 kinds. Preeclampsia or eclampsia, they're kind of grouped together. Chronic hypertension, so preeclampsia is something that develops because the woman is pregnant. Chronic hypertension is she had hypertension before she was pregnant. You can have chronic hypertension superimposed with preeclampsia. And you can have gestational hypertension. Okay? Basically in a nutshell, preeclampsia is diagnosed with an elevated blood pressure, and we'll get to those slides. It's an elevated blood pressure, and she's spilling proteinuria. Okay? Those are the criteria for diagnosis with preeclampsia. And they diagnose this usually after 20 weeks. Okay? And then there's chronic hypertension. So chronic hypertension superimposed with preeclampsia is so she has hypertension coming into the pregnancy, and then she starts spilling protein. So that's how they determine that. And then gestational hypertension is hypertension that started after she got pregnant, and it's not associated with proteinuria. Okay? Yes?
Is the preeclampsia one the only one that's usually diagnosed after 20 weeks, or are they all?
No. Preeclampsia. Yep. Yes.
When you say spilling protein, sorry if we've already gone over this, but that's like into the blood, right?
I'm sorry, urine.
Okay.
Proteinuria. I'm sorry. So spilling protein into her urine.
Which usually shouldn't have any protein, right?
Right.
Why does hypertension make you?
We're gonna learn that.
Oh, okay.
Okay, so this is what it looks like in pregnancy. So we have this hypertension, and it also causes this vasospasm. Okay, so in pregnancy we lose resistance to angiotensin II. Okay, right? So do you understand that sentence right there? So we lose resistance to it. So we're letting it run rampant in our system. All right. We have a decrease in prostacyclin, which is a vasodilator and a platelet aggregator inhibitor. And then the thromboxane, which is a vasoconstrictor, platelet aggregator, and it dominates. Okay, so if you just kind of think about those things and see how, yes, this does affect blood pressure. A decrease in the prostacyclin, which is a vasodilator. So we're letting angiotensin run rampant through our system, and we're not, we don't have enough of this prostacyclin. Okay, so that's setting us up for hypertension. Now, what that's going to do, the hypertension and the vasospasm is going to now affect our renal system and our glomerular filtration rate, which is why we'll end up spilling protein. So we have a decreased output, urinary output, and a retention of sodium, okay, which causes an extracellular volume, fluid volume, okay. This also leads to an increased sensitivity to angiotensin II. So up here we're resisting, we have a decreased resistance of angiotensin II, so it's running rampant. And now down here, because of our renal, it's affecting our renal, now we're also very sensitive to it. So it's a double whammy. Okay, do you see that? All right. Now, I'm just telling you, I'm not going to test you on these specifics, okay? But I want you to have a basement understanding of this, okay? Because of our glomerular filtration rate is hampered, we're not excreting our creatinine, our BUN, and our uric acid, so those are building up in our blood system, okay? But we are excreting large amounts of albumin, and then that's going to affect our extracellular, increase our extracellular fluid. So, yes.
Can you actually visualize the protein in the urine? Okay.
No. No. Okay, so now we have all this going on. We have our hypertension, we have our vasospasm going on, we have our poor renal perfusion. Now it's going to decrease our placental, our uteroplacental sufficiency or our perfusion to our uterus. Okay, and that's what affects the baby. Yes.
Sorry. Is the albumin excretion due to the protein in the urine being excreted, or is it like a compensation from the liver to try and decrease the volume of blood and decrease blood pressure?
So the albumin, I think because of the glomerular filtration rate and it not excreting the other things, like the albumin is being pulled out, just like the protein,
Okay.
in a sense. Okay. So, anyways, we're hurting our perfusion to our uterus, which hurts our perfusion to our placenta and to our baby. Okay. All right. So that's just kind of the basement physiology there. Now, so preeclampsia is when we have high blood pressure and protein in the urine. So if our blood pressure is greater than 140/90, and we're spilling 300 milligrams of more of protein urine in a 24-hour urine, or if you use a dipstick in your clinic, which is probably what you're going to do, it's 1+ on the dipstick. Then she's diagnosed with mild preeclampsia or just preeclampsia, okay? She may or may not have a weight gain with all that that blood volume that she's retaining, or fluid volume she's retaining. You might see a weight gain. You might see edema, but edema is not a criteria for diagnosis. It is the blood pressure and the proteinuria, okay? Now, if her blood pressures are now also elevated even more, over 160/110, and she's spilling 5 grams in her 24-hour urine, then she's diagnosed with severe preeclampsia. Okay? Now, if she's diagnosed with mild preeclampsia, they're probably going to manage her on an outpatient basis. But if she's diagnosed with severe preeclampsia, she's bought her a room at the hospital. Okay? So that's the big differences between those two. Is one can be managed on an outpatient basis, the other one needs to be, well, that's not the differences, these are the differences, but one's managed on an outpatient basis and one is managed on an inpatient basis. So these are other signs and symptoms related to all that basement physiology. Is we start having visual disturbances or head problems. When we assess patients, we ask them, how's your vision? Do you see normally? Do you have any halos or any spots in your vision? Have you been having headaches? Those are big assessment questions on your pregnant patient that has a blood pressure issue. Okay? We do, listen to her lungs. The other big criteria is, are you having any pain in your upper stomach that doesn't seem to be related to your uterus, or doesn't seem to be cramping? Like you have pain up high in your belly, that's constant. Okay, that's another big red flag for us with worsening preeclampsia. So these other things are only going to be seen on lab values, assessment of the baby with measurements or ultrasound. HELLP syndrome is diagnosed a lab value, so we're looking for hemolysis, elevated liver enzymes, and low platelets. That's what the HELLP stands for, and that's a worsening preeclampsia. So their liver is now being involved, okay? The other assessment criteria is hyperreflexia and clonus. So you'll be checking DTRs on your patient. And if she has brisk +3 more than normal deep tendon reflexes, then she's probably in a severe preeclamptic episode, okay? If she has clonus, which is you assess, you take her foot and you dorsiflex it, her foot towards her knee, and if her foot goes like this and bounces, then she has clonus. And hyperreflexia and clonus are indications of impending seizure activity, okay? Which is eclampsia. So for a preeclamptic patient who ends up having seizures, she's now an eclamptic patient. Her blood pressure has jumped so high that she has involved her liver and her CNS. She's hyperreflexic, so her DTRs are plus brisk, and she has clonus, so she's bouncing that foot. Then she's, and she has a seizure. So it's just like anybody else with a seizure disorder. You know, you want to minimize stimulation of their central nervous system, okay? The same thing with a woman. We got to minimize central nervous system stimulation to help prevent her from having a seizure. All right? So,
How would you do that?
so quiet environment, dark room, no loud noises, no bunch of family activity in there. Like, we kick everybody out, we turn everything off, and we basically put these people in a cocoon as much as we can. And then they're also on magnesium sulfate is a medication that we give in the hospital. It's a hospitalization, it's an inpatient medication. It's a IV drip. It's a very, very, very dangerous drug. It's one of those black box drugs where we need 2 RNs to hang this med. Because we can kill a patient within 15 minutes with this medication. But magnesium sulfate lowers or lengthens their seizure threshold. So when she has these astronomical blood pressures that's affecting her CNS, her seizure threshold has just dropped. That means that she is very susceptible to having a seizure. Mag sulfate raises that threshold to prevent seizures. As a side effect of running mag sulfate, a side effect of mag sulfate is hypotension.
Mm-hmm.
So it does help their blood pressure, but we don't give it to lower her blood pressure like we'd give labetalol or something like that. Yes?
What are the risks of a seizure, grand mal convulsions? Like what does that cause?
Well, it doesn't really cause a whole lot unless the woman breaks herself some way. But if she's not having good oxygenation during her seizure, as long as that seizure is lasting, neither is baby.
Got it.
So I have had a woman, and eclampsia and preeclampsia are really scary stuff because the person can come in and say, I just don't feel well. And that's the only complaint. Well, what doesn't feel well? Well, I don't know. I just don't feel well. You put her in the bed and you take her blood pressure and it's 200/110. Okay? And, you know, maybe with that woman you have time to get the IV in and get the mag going. But with the one that we got, we did not. Her blood pressure was 220/180. And she came to the floor and her only complaint was, I don't feel well. And so we said, okay, I can't remember what she told us, but we took her wheelchair and we went right to the room. Before we got her in the bed, she had a grand mal seizure. And she did not stop seizing until we got her under anesthesia in the OR. So these seizures don't just stop, you know, like grand mal seizures, you know, someone can have a grand mal seizure and however long it takes, 60 seconds or something like that, and then they're like, oh my God, what happened? They don't stop.
Was the OR so she could have a C-section? Or
Yeah, it was in the OB department who has a dedicated OR for emergency C-sections.
that's what they were going for?
Yeah.
does the increased temperature, hyperthermia that a grand mal can cause, that would affect the fetus though, right?
Oh, yeah. You mean the hyperthermia or the
Yeah.
seizure?
No, hyperthermia.
Oh, yeah. Oh, yeah.
Caused by the,
Oh, yeah.
caused by the seizure.
Oh, yeah.
Or the lactic
Oh, okay, I
acid
see what you're
buildup.
saying. Huh?
Or the lactic acid buildup.
Oh, yeah. So, so anyways, this is pretty critical stuff. So if you have a patient in the clinic that has blood pressure issues, education about, there's not really a diet, so we can't say low sodium because sodium really doesn't have anything to do with the pathophysiology except, she's going to be retaining it and now she's going to be third spacing. But, we put these patients on bed rest. We tell them to sit on their left side because we want to increase that uteroplacental perfusion. And if we have them on blood pressure medications, we encourage them to take those, of course. And usually we don't have them on blood pressure medications if they have mild preeclampsia, because it doesn't really fix the basement pathology that's creating the hypertension. So we might transiently lower her blood pressure, but until we fix that basement pathology, and which usually doesn't occur until the placenta is delivered, it's not really helpful. And then if they have preeclampsia and deliver their baby, they're going to be on that mag sulfate even 24 hours after their baby's born because they still have high risk for seizures after baby is born because of circulating hormones, they think. So the diagnosis, the treatment for preeclampsia is delivery. But we don't want to deliver a 32-week preeclamptic unless we absolutely have to deliver a 32-week preeclamptic.
If someone had to be on a mag sulfate drip, would they have to wait to start breastfeeding until they weren't on it? Okay.
No, they can still breastfeed. It might make baby a little poopy, but so it's a CNS medication, so it's going to depress the CNS. So they're going to be lethargic, they're going to be sleepy. And this is the reason why this drug is so blasted dangerous, is if the nurse programs the pump wrong and gives her too much, we can totally knock out her respiratory center. And that wouldn't be good. Someone doesn't breathe because of mag sulfate toxicity. So that's why,
Is there a reversal?
calcium gluconate. So that's why it takes 2 RNs, because when we give mag sulfate, we do have to give a bolus of it. And we have to give it at a very precise rate and for a very precise period of time, 15 to 20 minutes. So if we screw up our calculations on programming that pump to deliver that bolus in 20 minutes, we could basically overdose this person in 15 minutes on mag sulfate. So it's ugly. It's an ugly drug. All right. Okay, so I'm going to go through, I think I'm going to go through the rest of these pretty quickly. I've put some great, I've got lots of PowerPoints, and I think I've got a big graph table that's really going to be helpful. But these are things that we test mom for prenatally, so when she comes in for one of her initial prenatal visits, we're going to ask about, the big question is cats. Do you have cats in the house, and do you eat raw meat? But anyways, we're gonna test a rubella. I don't know if they actually do cytomegalovirus virus testing, or if it's just women at risk. So I don't think the herpes and the cytomegalovirus virus are a standard. I think they do those just for women at risk. But we do the group B strep test, but that's not until 36 weeks. And I'm actually not really sure if they do human B19 parvovirus on a routine basis. But those are big. Those are some of your big things that might affect baby. So here are the risk factors for a baby that mom has a toxoplasmosis infection, and you can look through those. Here is our treatment, and for both mom and babe, and treatment will not be on, meds will not be on your exam. Okay, this is just for your information. Okay, so here's rubella. Okay, fetal risk for rubella. Cytomegalovirus, fetal risks, and herpes fetal risks. Okay, you guys can look through those. Herpes is a pretty common thing, and they start treatment on mom if she's positive. Yes.
Are we worried that the infection is going to spread to baby? Is that what causes the fetal risks?
Right.
Okay.
Herpes. So they might put mom on acyclovir. Maybe around 32, 36 weeks to prevent an outbreak. And if we can prevent an outbreak, then this woman can deliver vaginally. Because the transmission for herpes, just like cytomegalovirus, usually occurs around the birth time, and especially with the herpes virus if she has open lesions. So if she has open lesions, she gets a C-section.
Is it worth the risk to have a vaginal birth?
With herpes?
If you have no
So,
lesions?
yeah, so we do it all the time, and it's pretty rare, okay?
It's pretty rare that
To
it's
get across it,
transmitted?
yeah,
Okay.
okay? So anyways, so GBS, these are our problems with GBS. Now, we don't screen mom until around 36 weeks. GBS is a common Normaflora type bacteria that half of us in this room are carrying around right now. And this does not make us sick. But if our baby is born through our vagina and we have GBS bacteria, then our baby will get extremely sick. So we test about 36 weeks, and if mom is positive, then we will treat her in labor with IV antibiotics. And it's not actually to treat mom, it's to treat the baby, to prevent an infection in baby. Okay?
Does it cross the placenta?
What? The antibiotic?
Yeah.
Yes. So the problem is you have this woman who comes in with no prenatal care, and she delivers her baby, and you have no idea what her GBS status is. So on those moms, we go ahead and run penicillin or whatever antibiotic in labor. If she comes in and delivers the minute she walks in the door, so she doesn't get any antibiotics, then baby's going to have to be on high surveillance, maybe even in the NICU, and started on antibiotics maybe as well.
How did babies ever survive?
Right?
before?
Right?
It was a much lower rate.
Yeah.
That's why people had 13, because 10 were going to die.
Yeah.
It's true.
All right. So anyways, you guys can look through those. Okay. So here we're going to talk about the RH stuff. So RH is a blood group. Okay. Women are either RH positive or they're RH negative. And if a woman who has RH negative blood is exposed to RH positive in any way, shape, or form, then that triggers an antibody response. Okay. And what will happen is, so she's considered sensitized, or alloimmunization or isoimmunization. Okay, that all means the same thing. She's been sensitized. Okay, so she is Rh negative and she's been exposed to Rh positive blood and she has developed antibodies. Okay. Now,
I have a quick question.
yep.
If the mom is a negative and the dad is a negative, then there's no way the baby can be positive, right? So she wouldn't have to worry about.
No, so there is a way she can be positive. So just depending on what dad's parents were and what,
Okay.
which sperm got the negative and,
Okay.
Negative recessive?
huh?
Isn't negative recessive when you have to have a double Negative.
Uh,
A negative from each parent to be negative?
A negative from each parent to be negative, so that, yeah, I'd have to review
So
that.
the baby's probably going to be positive if dad's positive.
Right, there's a smaller chance. And yeah, I think if you're negative, you can only give negative because it's recessive.
Okay. I'll have to
So
look
if
that
they're
up.
positive, they could be positive or negative, but if you're negative, they're only
I
negative.
think. Maybe it's
Well,
more
well,
complicated
I'll
than
look that up. I'll look that up. Yeah, that's kind of beyond me. I'll look that up and email you
If
guys.
it's recessive and dad's positive, then the kid will be positive.
How often?
Not necessarily because
They don't
he
test
could-
it.
dad
They don't
could have
test.
a
They don't
positive
usually
and
test
negative.
dad.
So
Don't
there's a 1 in
usually.
4
I mean,
chance.
sometimes they do, but not usually. What's going on?
Oh,
Did you
well.
guys figure it out? I'll look it up and email you guys because I guess I'm not 100% sure. Anyways, yes.
So the question I have is why are they only giving this Rogam or whatever post-delivery?
They're not just giving it post delivery. So
They give the shots throughout.
yeah. So they get one prenatally and then they may get one post delivery. Okay.
But why post-delivery? Because it's not like the kid's bleeding all over you or something, I don't get it.
For the next one.
It's for the next one.
Yeah, it's not actually to treat this baby in utero. It's
Yeah,
to
not the baby, but the mother.
But she's been exposed, so she should be sensitized.
Okay, let's go through a few slides and then let me know if you still have questions, okay? So an Rh negative mom is carrying an Rh positive fetus. Either at delivery or termination of the pregnancy, she can be exposed to the Rh positive, okay? The other possibility is an Rh negative pregnant or non-pregnant woman, doesn't really matter. They get exposed through maybe even a blood transfusion that's positive. So we need to find out in her when we do a lab testing. So we need to find out if the mom is Rh negative. We need to find out if she has been sensitized already. Okay, so we'll do our indirect Coombs test, but we'll see that. Okay. So anyways, mom's exposed to a positive baby, and if this is her first baby, then that's not an issue for this first baby, because by the time mom has been exposed, usually at delivery, or at some trauma or something, or an invasive procedure, mom hasn't built up the antibodies to now cross the placenta to go attack baby. Okay, so it's not the first baby that's the problem. It's subsequent babies that could be the problem, if those babies are Rh positive, which we don't know in the prenatal period. So when we have an Rh negative mom, we test her, we find out she's Rh negative, then we also do an antibody screen to see if she has developed any antibodies. If she hasn't, then we can go ahead and give her the Rh immunoglobulin at that point to prevent her from developing antibodies, okay? And then, so what it does to baby is when mom does produce antibodies, when the antibodies cross the placenta, it causes all these problems for baby. And these are problems that develop in utero sometime before birth or right at delivery or during the labor, and so they start at that time, and then when baby is delivered, then these all get increasingly worse. Okay. So we give the Rh immunoglobulin to mother. And that's if, ooh, I'm out of water. We give the Rh immunoglobulin to the mother if she has been exposed to or sensitized to Rh positive blood. Okay? Which is different from the Rogam we give her, but we'll see that here in a minute. All right, so we find out she's Rh negative. We do the antibody screen. It's an indirect Coombs test is what it's called. If that test is negative, that means she has not been sensitized, then we will rescreen again at 28 weeks. And then at 28 weeks, if it's the same, then we'll go ahead and give the RhoGAM. RhoGAM is a product that we give to keep her from, if she gets exposed, to producing antibodies. Okay? So the immunoglobulin that we give is she's already been exposed and creating antibodies. So if she is, if she has produced antibodies, that means she's sensitized. They'll do a titer to kind of evaluate the extent of that, and then just manage the pregnancy. Just try to support the pregnancy until delivery, okay? And hope that we get a baby who hasn't had a lot of that hemolysis going on, okay? I know this is confusing. So let's start with questions.
I don't even know.
So if mom is Rh negative, she comes in, she's pregnant, we're going to test her. We're going to see if she's developed any antibodies, okay? If she's developed antibodies, that means she's been sensitized somewhere. So a previous pregnancy, a blood transfusion, something, okay? So she's been sensitized, all right? And then they're going to do this titer. It's kind of an antibody count to see what is the severity of that. And they will give this immunoglobulin at that time.
That's
Now,
if she is somehow sensitized.
right, okay? So, so she's been sensitized, so she's creating antibodies to Rh positive blood. And if her baby is Rh positive, those antibodies are going to cross the placenta and attack that baby. Okay? So we got that? Mm-hmm. All right. So if we test her prenatally and we find out that she's Rh negative and she has not produced antibodies, so she's not sensitized, okay, then we will give her RhoGAM to prevent her from being sensitized prenatally. Okay? And then when she goes and delivers, if her baby is Rh positive, then we test mom again, and if she's not sensitized, we dose her again. Okay? And this will hopefully prevent her from developing antibodies, so when she has a subsequent pregnancy, it's not going and attacking that next pregnancy.
So the globulins are binding to the antibody, and the RhoGAM is like inhibiting the production of antibodies?
Right.
Like,
oh, yeah. That's
so does it, are you like immunodeficient then essentially if you're on RhoGAM for a little while? Is it like the B cell or?
Only for that specific,
no,
specific
yeah.
type.
Yeah. All right. So with the baby, if the mom has been sensitized and now those antibodies are crossing the placenta and attacking baby, depending on the severity of that attack, we may end up, one, delivering early so we can manage baby on the outside, or we may end up doing an intrauterine transfusion, a blood transfusion while the baby is still in mom's uterus.
With a big needle.
Yeah. And
What? With a big needle?
well, no, not with a big needle.
Like, how do they do that?
They do it in a surgical. It's a surgical type procedure. They do it in an OR. They do it under ultrasound guidance. They cannulate the umbilical cord, and they do a transfusion in utero. They can do some crazy stuff in utero. I've seen a thoracentesis. This.
So they're sticking the needle into the
Cord.
into the cord. Okay, so it's like, man,
Because the cord's basically a blood
it's
vessel
hard to
for the
find
baby.
things.
Yeah, yeah, yeah.
Outside.
Right.
They're trying to pull us down and help you guide that.
It's fine, you got
Get into the right vessel in the cord.
That's what I was thinking.
Okay, so so these next few chapters I'm going to go over very quickly. Please stop me if you have a question. Okay? These are kind of labor type. This is labor type of stuff. So this is inpatient, but I'm presenting it to you so that you have a knowledge base to share with your patient. Plus it is on your NCLEX. So we should probably go over it. But I'm going to go fast. So if you have questions, please stop me because we only have 20 minutes. So factors that affect labor, of course, is the passageway, which is the birth canal, the fetus, the forces of labor, which is contraction strength and abdominal pushing strength, the position of the mother, and psychosocial stuff. Okay? So there's a true pelvis that starts at the inlet of her pelvic bone, and then there's the mid-pelvis and the outlet, so actually down through the birth canal. There's 4 types of pelvises: gynecoid, android, anthropoid, platypoid. Their shapes are indicative of whether or not this woman will be able to deliver vaginally. So there's 2 pelvises up there that can deliver vaginally. Which ones, by looking at them, do you think?
The 2 on the left.
The first one and the third one.
The first one and the third one. Okay? If your woman has these shaped pelvises, she will, most 99.9% sure, will not deliver vaginally. That baby will not come down through the birth canal. All right. So the fetus, so that head's coming down through the birth canal. The head is broken up into several bones. So the baby's head is, the skull of the baby's head is not one solid bone like ours is. They have 2 frontal bones, 2 parietal bones, and an occipital bone, and those bones are meant to overlap so baby can fit through the birth canal. Okay? And then eventually as baby grows, those fuse together. Okay? So as those bones overlap, then we get that molding of the head where it looks like a cone head baby. All right? Between those bones, let's just look. So these are sutures, okay? So this is between those bones. So they're not, those bones are not fused together. They're open, and they could be touching, or there could be just a tiny little space there. But when that baby comes down through the birth canal, those bones will overlap, okay? But where these bones meet, those areas of soft spot, they could be quite large, but those are called fontanelles. Okay, so that's just what they're called. When we do vag exams to see where the baby's head is and what way the baby's head's facing, we're feeling for these sutures and we're feeling those fontanelles to try to get an indication of which way baby's going. Okay?
Outside of the mother's abdomen?
No, we're doing a vag exam and checking baby inside, in labor.
Oh, okay, gotcha.
It helps let us know which way this baby is coming and whether or not this baby will make it through the birth canal. Okay? Here's just another picture of that. Okay? Now, when we talk about fetal attitude, we're talking about the relationship of the baby's parts to itself. So, if baby's attitude is flexed or normal, then, you know, this is the fetal position. Baby's all tucked up, okay? If they're not flexed, then the baby's just laying in there like this, like a rag doll, and that's not good. That's not good for trying to deliver a baby. That's all just, okay? So here's what it looks like. This is a normal attitude, or a flexed attitude, okay? Now, fetal lie is the relationship of the baby's spine to the mom's spine. So if you can imagine, if we want babies to come out head first, we want the head down, the butt up, we want the spine going this way, right? That's the way it goes if your feet are here and your head's here. So baby's spine is going the same way as mom's spine. If baby's spine is going the other way, so head's over here, butt's over here, legs are over here, then the baby's spine is going this way, so it's transverse to mom's, okay? And those, a transverse baby doesn't usually come out vaginally.
I can imagine.
Okay, engagement refers to where that presenting part of the baby, what part of the baby is fixed down into the birth canal, okay? And we assess that and term that called station. So what part of that baby's head is at the ischial spines of the woman's pelvis? So here's our ischial spines. So what part of the baby is meeting those ischial spines? Okay? So if the baby's, if the presenting part is down here at those ischial spines, then we say that baby is engaged, okay, in the pelvis. And then as baby keeps descending, that head keeps pushing through that pelvis.
Is there, I'm sorry, with those diagrams, why the one baby seems much more developed than the other baby?
Oh, no, I don't think that's, I don't know. That's not a,
Maybe on top shaves his head.
And
Yeah.
they also look like they're kind of different positions.
right.
But they're just trying to show you from the front and from the side. as
Right.
well? Okay.
So it's different sections, cross section of mom's pelvis. So anyways, when we say station, so when I said baby's presenting part is at the ischial spines, here's the ischial spines. That is 0 station. And that just tells us how high up in the pelvis baby is. So if baby's above the ischial spines, then we call it -1, -2, -3, so forth, so on, centimeters. So if I say this baby is at -2 or -3 station, then that's telling whoever I'm talking to that the baby is really high up into the pelvis. Okay? If I say baby's at +1 or +2 station, then that means that baby is moving down through the birth canal. Okay?
You put some landmarks with those bones.
What?
You put some like landmarks with the bones, like that's the cervix at the end, +5.
So probably at 0 station, so my cervix is depending, I mean it could be anywhere actually. Is that what you're asking? Where's the cervix compared? So if baby's at 0 station, usually the cervix is right at 0 station as well. Okay? If baby's at -2, well my cervix may still be at 0 station, but baby's way up there. Okay, so you know, some cervixes are in the front, some are in the back, some are really high, some are really low. So a general rule for, yeah. Okay. All right. So the other thing we talk about is, so when I went in there to feel baby's head, and I felt those sutures and fontanelles, I was trying to determine which way baby was facing, so I want to know if baby's going to come down face up or come out face up, which is not we don't want babies face up, because it's just harder for mom and more traumatic for baby to push a baby out face up. We want the back of baby's head to be up. Anyways, so we want to know what the back part of the head is. So this part of the head, okay, is it's the smallest diameter, okay, and yes, it gets bigger as we go down. We want that part coming through the birth canal first. That would be the best, greatest thing for mom, okay? But this part of the head is called the occiput, okay, occiput. We want to know where that occiput is facing. Is that occiput facing her anterior, or is that occiput facing her posterior? Is that occiput facing right, or is that occiput facing left? So that's why we have all these different, all these different right and left. So mom's right, mom's left. The occiput is what part of, or where's that head facing? Okay, is it anterior or posterior? Is the occiput anterior, which means baby's coming out face back, head forward, so that's the best way. Or is that occiput facing mom's posterior, so the back of baby's head's here, the front of baby's head's here, which is the face, which is sunny side up. Okay. So anyways,
What would transverse be? It's baby was transverse.
so transverse is,
Face
yeah, transverse is more so like that baby whose spine was running this way, okay? Now we can have the occiput facing transverse, but it gets all confusing because it's part, so it's coming down and it might be facing right, but it's facing like this, okay? So, yeah, it can get really crazy, all right? These things you might want to know because these are the signs of labor. So this woman's going to be coming into the clinic saying, I think I'm in labor. You're going to ask, do you have any of these things going on? Okay? And if she does have any of these things going on, you might say, well, you probably better go to the hospital and get checked. Okay?
What's lightning?
The baby dropping, like that she has an actual feeling of the baby's moved down.
Kind of a shift in the center of gravity.
Yeah, so she's used to carrying her baby out here, and now she's carrying her baby right here. So, okay. Now she comes to the clinic, and you ask her about all those things, and you send her to the hospital, and so we put her on the monitor. We check her cervix, and we see that she is contracting. We check her cervix for effacement and dilation, and then we get her up and we walk her for an hour. And then we get her back on the monitor and recheck everything again. And if there was no cervical change, I don't care how often she's contracting, and I don't care how painful she thinks they are. If her cervix did not dilate in that hour, she is in false labor. Or she's not in labor. She's just having contractions, and the body does that, okay? So I will send her home, and she will hate me forever. But for true labor, she has to have cervical dilation, a change in her cervical dilation, okay? The contractions are more regular. The pain is stronger. But I've had women who come in and they're contracting every 5 minutes. Like, I think they're in labor. Their contraction pattern is so beautiful. And they're rating their pain a 10. And they're ready for their epidural. And I check their cervix, and it hasn't changed, and I have to send her home. So,
Do you send her home or does the doctor?
well, the doctor does, but he never comes in. So OB nurses can assess and treat patients without OB physician in the facility. We have to call them, of course. Okay. All right. So here's just a little chart comparing the two. Most important is cervical dilation.
So that contractions occur at regular intervals in true labor. Does that mean once your contractions start, they're never going to come? I've always kind of heard, oh, the contractions are closer together.
Yeah.
That doesn't actually happen. It's like whatever you start at, that's
Oh, no.
the whole labor.
No. So if you come in contracting every 5 minutes, as your labor progresses, your contraction pattern will get closer.
That seems irregular to me then.
Irregular is I contract 5 to 10 minutes, so I'll have a contraction at 5 minutes, and then I'll have it again at 10 minutes, and then I might have it again at 15 minutes. Mm-hmm. That's irregular. What's regular is my contractions are every 5 minutes for an hour, and now they're every 2 minutes for an hour, or now they're 3 to 4 minutes every hour. Okay, so they're consistent across the period of time, and that can increase in frequency. Okay. But a contraction pattern that's, 10 minutes apart, 15 minutes apart, is not a regular pattern. Okay? So I put the slides in for pharmacological management. Not that I'm going to test you on any of these. I just want you to be aware because you will be educating your patient. Okay? Because she'll say, what are my options when I go into labor? And you will tell her what her options are. So, as far as IV push medications, Stadol, Nubane, Demerol, and fentanyl are 4 of the common medications that we get in labor. And they're IV. She can have them every 1 to 2 hours depending on which medication it is. I have included the slides about all this information, route, dose, blah, 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 on each one of these medications, okay, for you to review. Here's also another one of these lovely charts, okay? other things that we can give during labor to help potentiate those narcotics. Phenergan is a big one. Vistaril, I've never seen these other two given. But they cause sedation, and I guess a narcotic does too. But their main use is to potentiate or to improve or increase the level of effectiveness of the narcotic we gave. Okay? Is their main purpose. All right? Now, if we've given a woman too much narcotic, we can reverse that by giving Narcan. Narcan is the reversal agent. If we give a narcotic to a woman and 5 minutes later she delivers the baby probably got narked, okay, and is not going to want to breathe and participate in life, and we can give Narcan to baby, okay? All right, regional anesthesias is the most common that we give. That's the epidural, the spinals that we give in labor. Epidural is a continuous drip of medicine to numb the woman, okay? It's the one we typically use in labor. So we can keep this medication running throughout her entire labor. It will never wear off because we'll keep it running. We may have to increase it a little bit, decrease it a little bit, depending on effects, but yes.
So I've been asking this question since like the beginning of anatomy, and no one has had a real definitive answer. And I'm wondering, where is there like a range of where you put an epidural?
Yes. So I think I've actually got a slide. So let me see if I get there. Okay. The spinal is somewhat different. A spinal is usually given during a C-section, where you want to dose the woman. You want to get to the spinal space, dose the woman, and then pull the needle out, and then she no longer has this continuous drip going. This spinal will last throughout her entire C-section procedure. Okay? All right. And the combined it usually happens when we have a patient in labor and she has an epidural, and then we go for a C-section, and then he pulls it back a little bit sometimes, actually the epidural, and then the spinal space is a little deeper, actually. So here I've listed advantages and disadvantages of each. I think I have a slide. Okay. So deep in is where the spinal nerves are, the spinal canal is the spinal space. And then there's a layer before that is the epidural space, and that's where the epidural goes.
So what, like, between which number of vertebrae is what?
Oh. So I think that they start at T12 somewhere. And depending on the woman's anatomy, they might go a little higher or a little lower. Okay. The anesthesia, they're pushing and trying to find the best place.
Okay.
I was told, no, I don't know, my family doesn't have much medical background, but my aunt, apparently they gave her an epidural and did the opposite. It went up.
It went up. Okay. So one, he may have put it too high. Yeah. So I think T10 to T12 is kind of a range. He may have put it too high. Or he put it in, and then they laid her flat on her back, and gravity let the medication flow up.
Yeah, she couldn't, everything was...
Right. All right, general anesthesia is another way we can give, it's not actually pain medicine, but it's putting her to sleep. These are reserved for emergency C-sections, or C-sections where they absolutely can't get the spinal in. They've done everything they can, and they can't get the spinal in. Or they got the spinal in and it's not working, whatever. But usually it's reserved for emergency C-sections where we need to put her out this very second and get baby out the very next second. Okay? They create risks for both mom and baby when we use general anesthesia. So we don't try to use them. We try not to use them as much as we can. So here are your dangers for general anesthesia. You guys can look over those. The last thing I want to cover real quick, we've talked about preterm, okay, right? We know what preterm is. Here's your symptoms for preterm labor. So if your patient comes in at 32 weeks to the clinic, and she's complaining of some of these, she might be in preterm labor. Here's your predictors for preterm labor. And I don't want you to memorize these. Like, I want you to look at these and say, yeah, like, definitely I could see why that would put someone in preterm labor. Like multiple gestation. So how many babies has she got in there pushing down on her uterus and cervix and her membranes, causing her to go into preterm labor? So just kind of try to put these things together, okay, instead of feeling like you have to do brute memorization. We do have medications that we can give women to stop preterm labor. Tuberculin or brethine is actually an asthma drug, but it relaxes smooth muscle, and uterus is a smooth muscle. Mag sulfate, that drug we gave for the hypertensive crisis patient, preeclamptic patient, we can also give that. Indomethacin is a new drug we've been using over the past couple of years. This is a PO drug that we can actually send them home on. Same thing with Procardia. Okay. Here's PPROM versus, or PROM versus pre-PROM. You guys can read over that, but I think we did review this, right? Did we one time? No. So PROM is a premature rupture of membranes. So their water breaks and they don't go into labor. Okay. So it's the water breaks and they don't go in labor. That's a premature rupture of membranes. But when you put it with PPROM, you're now putting it at a preterm age. Okay? So the water breaks and they're preterm gestation. Okay? Here's your risk factors for that. Here's...
Oh wait, sorry, that slide said that it was spontaneous rupture of membranes before onset of labor.
Yeah.
But would it make more sense to say in labor doesn't start? Because to me that means that labor is about imminent.
Well, labor, so yeah, I mean, you could have wrote it anyway, but the point is she's not in labor, she's not contracting, and we do anticipate labor to be occurring.
But that's a problem because it's too early.
Right, right.
Labor is contractions and
Dilation.
basement and dilation
Right.
of cervix, right?
So her water broke, she's not contracting, she's not dilating. Okay? All right, so here's your risk factors. Here's the things that can happen. Wow. I tell you what, since we're right time to go and you guys got an exam, I'm going to start at, I've recorded this lecture for a few people that aren't here, and I will go home and I will record the last, I mean, there's only a few more slides left. Actually, there's a few more slides left. I will go home and record this tonight and get it on Moodle so that you can hear my explanations for the rest of these slides. Okay?
Thank you, Wendy. Thank you.
Yep, you're welcome.
Oh, so I did those little box things for the kids, and I came up with, if you don't know what the father is, there's a 50% chance the kid is going to have positive. And if you know the dad is positive,